This is Michael Smith of MedPage Today. I'm here in San Francisco at the annual meeting of the American Association for the Study of Liver Diseases. I'm talking with Dr. Michael Goldstein of Columbia University Medical Center in New York. Dr. Goldstein is reporting an analysis of the way patients are allocated transplant livers, and the issue is an important one given the current shortage of livers. Dr. Goldstein, what exactly is the issue that you were looking at?
We have created an early access plan to transplantation in our region. We've done this because there's a dramatic organ shortage, and to save lives we need to try to recover and transplant as many livers as we can. Patients are allocated organs by MELD score, which is an assessment of how sick they are. Many patients are underestimated in terms of how sick they are by the scoring system, so they have no access to transplant based on the system. To save lives, we have recommended and we've been able to encourage our patients to pursue living donation and higher donor risk organs, deceased donor organs, so they have early access to transplant so they can decrease their morbidity and mortality on the waiting list. The purpose of the study was to validate this clinical practice that we've already practiced for many years.
I see. The issue is, I guess, that people on the waiting list move up on the waiting list by getting sicker and sicker.
That's correct.
Whereas the outcome for those sick patients may not be as good as for patients who are better earlier on in the process. Is that right?
That's correct. As patients get sicker, their MELD score goes up and they have better access to transplant. But it can take many years and many lives lost till you get to the point where you can be successfully transplanted in the current system. So to save lives and reduce death on the waiting list, we have allowed patients at our center to have access to living donation, and we encourage them to also sign up for higher deceased donor organs when they have no access to the standard organ that's allocated by our current system. We looked at the outcomes of 44,000 people over a 4-year period from the UNOS database to validate and justify our reasoning for doing this.
And you found, in fact, that the reasoning is justified, that if you transplant earlier, people live longer and are better off.
What we have found, if you look at the 3 types of organs that patients have access to, which would be a living donor organ, a standard risk deceased donor organ, or a higher donor risk organ, if you compare those 3 outcomes from the point of the time they're transplanted, the outcomes are very similar regardless of the type of organ you receive. There is a benefit of receiving a living donor over a standard deceased donor, of course, but the differences are relatively small. If you look at the time of the transplant, from the time that they're listed, the time that they present to my office, for example, that time that you transplant them is absolutely critical to their overall survival. So it's the early access to any potential transplant, regardless of the donor type, that actually saves lives.
I see. In the long run, you would like to see this MELD score, this reliance on the MELD score, changed in some way?
Well, I think the MELD score predicts early mortality or pre-transplant mortality very well, but it definitely underestimates illness as people are waiting on the waiting list. The global problem is there aren't enough organs to go around for all the people that need them, and that is why we triage organs to the folks who need them the most. Our current system allocates organs to the people who are most likely to die before those who are most likely to live. Now that could be totally counterproductive. If you look at the benefit to society as a whole, we would like to transplant the patients that are more likely to live than more likely to die. And that's how people are allocated organs. And that's what we'd like to do for the kidney allocation system, and I think we need to start considering that for our liver allocation system too. Consider not only the risk of them dying pre, but the risk of patients dying post to increase their overall survival for the society as a whole.
I see. Thank you very much for your time, Dr. Goldstein.
Thank you.
I'm Michael Smith, MedPage Today.